Really nice to speak to you on home turf. I know lots of you out there might have seen me talking about some of this before. I think most of this is all new. I've put in some special effort in not using any slides I've used with you in the past, so that's quite exciting. I've only been given 10 minutes, but I'm going to take that like an adult with dignity and plough on regardless and just talk faster. So why am I talking about QIPP and the QIPP work streams in particular? And aren't they old hats? They date from 2009 as the first iteration of QIPP when that came out, the Nicholson Challenge, and they were actually abandoned in April 2013 in favour of the 5 domains, which you might be familiar with, working with the outcomes framework. But why I think it was important and why I think it's still worth talking about was it was the first systematic attempt at managing the NHS funding crisis. And that was a funding crisis that seems quite small compared to the one we've got at the moment. So it was the first round of QIPP, they were trying to manage 15 to 20 billion, which seemed at the time an appalling amount of money, and now it's 30. So I think there is something in these QIPP work streams that can be learned from, and the challenges that they pose are still very much relevant today. So the broad thrust of this piece is how is the NHS going to re-engage with all the different things they need to think about when making these savings. So it's neither positive nor negative really, it's just questioning about how the NHS is going to do this. And a few things have already emerged from the NHS Confederation Conference, for example, that I attended last week, that are beginning to feel like ideas that are going to evolve over the next 5 years and become concepts that we will end up being really familiar with, the new QIPPs, the QIPPs of the future. So what are they going to look like? Some of the elements are going to be macro, they're going to involve sweeping changes at the top in the way we recruit workforces, and some are going to be more tinkering around the edges, micro elements. But with this you've got some bits that have remained, some bits of the work streams that have remained, some that have turned into other things. So this is going to trace some of that. You're going to see these figures quite a lot, the actual efficiency figures. I don't think we've had a slide that quite deals with this particular issue at the moment. So 30 billion is the shortfall that you've got to make by 2020 if absolutely no efficiency savings are made whatsoever. So 8 billion is what we're getting to cover the remainder of what you can't cover by the maximum amount of efficiency savings I think it's possible to make, which is 2 to 3% a year, which is still pretty difficult. At the height of QIPP, the high QIPP, 2012, 2013, when they were cutting, slashing, reducing tariffs and cutting staff here, there and everywhere, they managed to get it up to something like 5%, I think. But 2 to 3% per year, every year, that's going to be really difficult. So you need some kind of systematic approach to making this. And we're beginning to see some ideas coming from both Stevens and Hudson on this. The 12 QIPP work streams look like this. There were some ideas on commissioning and pathways, some on provider efficiency, some on what they called system enablers. They are now 12, and those were the levers that you could pull to try and make these savings in different ways. Now, I can't think of a single one which isn't still relevant. All those areas need to be worked at, and they can offer some cash releasing savings. What was the point? So if you focused on this, you could release 20 billion cash over 5 years. That was the original Nicholson Challenge. Did it actually work? Well, sort of, yes. 5.8 billion was actually saved by applying all of this in 2011-12, and another 5 billion in 2012-13. So that's about 5.5%, 4.6% of the total NHS budget. So in terms of percentage efficiency savings, that's looking quite good, really. So I'd say overall, judged on its own terms, and although it created a lot of problems as it went through the system, the Nicholson Challenge was, broadly speaking, answered. But he said himself, this is how they're going to do it. 40% is going to come from pay freeze, 40% of savings are going to be done from tariff. The 20% that remain is service change. So basically that first 80% you can't really do again. That's the bit that's been done, and done the tariff, tried to change the tariff again, depress it, that went down terribly, as Andy was saying before, seismic event and all that, and the pay freeze can't pay anymore. So there's 20% of savings around service change in the original one. That's what's going to have to be taken forward into the next round of QIPP, these transformational savings. If they don't happen, you're not going to make the 22 billion, simple as. So what happened last time? Where did NHS organisations decide to make their efficiency savings? They were given a pick list of various things, as you can see here. Now, interestingly for this audience, can you see what's at the top? Medicines management. So out of all the SHAs, there were 10. All of them picked medicines management as an area for efficiency. All of them are going to slash their medicines budget. And I predict that the same thing is going to happen here. There's other rationalisations you can make. As you can see there, in life care, long-term conditions, mental health care, plan care, all of these still exist, still live problems. Medicines management is the one at the top. Safe care. I'm just going to go through some of the original 12 work streams, see what happened to them. Safe care became harm-free care. Then the Francis report happened, that was the big story. Patient safety agenda is still completely paramount. Now the word is safety needs linking to efficiency. If you have airline levels of safety, and Mr. Hunt didn't say which airline, but if you have airline levels of safety and a zero tolerance regime for safety events, you will begin to see efficiency savings as well, not least in negligence cases and insurance. There's savings to be made there. So this airline level of safety regime is going to be launched this year. That was a trail that the NHS confed, and we're going to hear more about that later, I'm sure. Right care. So right care never really went away. That was all about reducing variation. You still got the right care atlas of variations, which some of you I know find helpful. That looks at prevalence, it looks at outcomes, it looks at spend. You can look at different disease categories, respiratory, diabetes, kidney, children and young people, renal, diagnostics and so on. And that is an ongoing project. It's never going to go away completely. But there's a new driver in town, which is Anytown. So Mr. Hunt mentioned this as well. It's a new benchmarking system. Not very fond of benchmarking systems on this panel, but it's going to be made part of the CCG's KPIs. It's based on efficiency and outcomes. It's got an indicator on transformation, what are you doing differently compared to last year, and it's also absorbed the technology and digital vision side of things. So what are CCGs doing to incorporate telemedicine? This is a look at some of the indicators in it, the kind of things that they're going to be marked on. Early diagnosis, reducing variability within primary, self-management, telehealth, case management and coordinated care, mental health, dementia and palliative care. What kind of impact is it going to have? Well, they say quite significant if it's implemented properly. So in secondary care you can get up to 24% efficiencies, primary care 5% efficiencies. Community care, they actually said the spend could go up, but by spending more on community care you can make savings in other sectors. Right, rattling through this now. Procurement. I think this is going to be the big story of the second half of the year. So it's a long backstory, Innovation, Health and Wealth 2011, and then various ineffectual strategies which didn't actually make hospitals spend any less. The NHS Atlas of Procurement Variation, which went down like a lead balloon with industry because it didn't take into account rebates. Then something called Better Procurement, Better Value, Better Care came out. That aims to save 1.5 billion. Is it happening? Not really sure about that at the moment. Then there was the zero inflation price freeze, which you're all familiar with. Now we've got a new review coming out, Lord Carter's review, going to be out in the next couple of months, I think. And then look out for this document called the Model Hospital. So that's about how all hospitals should be procuring. What efficiencies are achievable in all the major product categories. And then every trust is going to have to agree a target from September with NHS England, and that target is going to be set in stone, and then it kicks in January, and they're going to have to make a whole bunch of savings on loads of product lines. So, the final three, long-term conditions, urgent and emergency care, end-of-life care. So these have really been absorbed into trusts and TCG plans via the outcomes framework. There's no kind of national system driving improvements in quality, innovation, productivity, and prevention then as such. But you are seeing all of course, what we've mentioned is, so far today, the 5-year forward view models are trying to improve value as well as quality. And the ongoing A&E crisis, which is maybe sort of perhaps on the mend now, coming out of the end of the tunnel, reaching their targets now. So I don't know if that's going to take as much of a focus as it did in the past. I may be wrong. Back office efficiency and optimal management, that's been used widely, as we've seen lots of back office cuts already, but as I mentioned in slide 3 or so, it's got to the point where there's no more staff cuts available really. And there's also a focus on recruiting, of course, especially the clinical staff, the doctors and the nurses that were promised in the Tory manifesto. So workforce reform isn't really a money-saving option anymore. Productive care, very, very quickly. So that was a series of manuals, really. So the productive operating theatre, the productive ward, you might remember these, and some of these were taken up by trusts and did have some results here and there. Hunt wants this to be much more systematic. Toyota lean processes, he mentioned that in his plenary address a couple of weeks ago, and other kind of productivity measures borrowed from industry are now going to be brought into hospital trusts, and I think we're going to see a lot more of that over the next couple of years. So, I think more than ever you need a new QIPP 12. You need some kind of rationalisation of all the different things, all the different levers you have to pull if you're a trust, if you're a commissioner, how are you going to make all these different types of savings? Because it's not one thing that you do, there's not one big solution to all of these, not one big sword that you can just cut through all of this. You need lots of little attacks. So, especially as these efficiency targets are going to be even harder than previous years. So 2% was the average in QIPP round 1. It's going to be up to 5% per year in this round, particularly for some of the trusts that have taken the default tariff rollover position, which is going with the last round of tariff prices, because they have been set as a penalty for taking that an even harder efficiency saving. So the NHS needs to come up with creative new ways to save money. How can you help with this agenda, and how can you manage this threat? Is my questions to you.